Nearly half of U.S. physicians experience burnout. The high-energy stress of frontline care eventually collapses into a heavy, unyielding exhaustion. This condition is routinely misunderstood as standard occupational fatigue. It is not. Clinical evidence defines burnout as a highly specific, measurable occupational syndrome. The pathology is characterized by three core dimensions. First is emotional exhaustion. Energy completely degrades, leaving providers unable to recover. Next, depersonalization. Involvement turns into severe cynicism, reacting with detached apathy. The final dimension is reduced accomplishment. Clinical efficacy plummets. Together, this syndrome afflicts half of the active workforce. The clinical literature links this syndrome to specific, measurable harms: an increase in medical errors, reduced patient satisfaction, elevated rates of substance misuse, and provider suicide. Hospital administrations frequently respond by deploying isolated individual resilience modules, directing staff to meditate or practice self-care. Clinicians counter that deep breathing cannot fix a structurally broken workplace. Treating this syndrome requires dismantling the false dichotomy of resilience versus reform. By auditing the clinical evidence for both approaches, we can see exactly what works, what fails, and how they must integrate. We begin with individual-focused interventions. These strategies are heavily criticized as cheap band-aids for broken hospitals, but the clinical data reveals them to be highly valid tools for acute stress mitigation. Mindfulness-based interventions, in particular, serve as highly scalable mechanisms capable of generating a measurable physiological impact on the provider's nervous system. This chart compares intervention lengths. A 15-minute daily mindfulness session significantly decreases stress. Extending the timeline to an 8-week program shows a vastly deeper drop in anxiety and depression. The payoff is immediate: increased clinical insight and a decrease in medical errors. Beyond mindfulness, evidence supports cognitive behavioral techniques. Dedicated stress management skills and communication training equip providers to navigate high-friction clinical environments with less cognitive load. Reflective practices, like journaling for gratitude and narrative medicine, offer structured methods for processing the intense emotional demands of the daily workload. Interventions rooted in positive psychology, such as cultivating a growth mindset and learned optimism, build cognitive armor that reduces a provider's susceptibility to chronic stress. These psychological tools rely entirely on a foundation of baseline self-care. Good sleep hygiene, a balanced diet, and regular physical activity are non-negotiable prerequisites for cognitive resilience. Individual cognitive and mindfulness tools effectively maintain a provider's acute clinical functioning. They buy time and preserve capacity, but they cannot resolve an unsustainable workload, and they are incapable of preventing structural burnout on their own. Moving from cognitive strategies, we find strong evidence for somatic interventions, physical practices designed to directly regulate the nervous system. Sudarshan Kriya Yoga combines gentle stretches, meditation, and highly specific rhythmic breathing exercises to alter the body's physiological stress response. This radar chart maps the results of a 12-week randomized controlled trial on this specific yoga intervention. The data demonstrates highly significant improvements across all three dimensions of burnout simultaneously. Because this trial utilized a mobile health delivery mechanism, it bypassed the primary barrier for overworked staff: scheduling. Digital delivery allows providers to access interventions exactly when their shifts allow. These accessible physical practices directly correlate to measurable improvements in the overarching professional quality of life for healthcare workers. The data also indicates that younger and female physicians show variable susceptibility to chronic stress, requiring customized and targeted access to these interventions. To anchor these somatic practices in reality, providers require robust social support, relying heavily on meaningful family relationships and structured peer discussions. Mobile health tools and somatic self-care provide measurable physiological shielding, yet they still operate strictly within the confines of the existing clinical environment, bringing our analysis directly to systemic failures. You cannot meditate your way out of a toxic workflow. Organization-directed interventions targeting the work environment are strictly essential for sustainable burnout reduction. At the macro organizational level, burnout is an engineering failure. It is the result of a severe mismatch between the cognitive resources of the provider and the structural demands of the medical system. This blueprint maps the hospital workflow. Administrations must implement modifications across 3 structural pillars: workload, team culture, and support structures. The primary driver overloading the workload pillar is clerical bloat. Excessive administrative burdens and inefficient processes generate massive friction for frontline staff. When these inefficient processes force clinical work into personal hours, severe work-home conflicts emerge. This specific friction deeply erodes the retention rates of care providers. Further degrading the system is the frequent lack of physician input in management decisions. Exiling clinical staff from operational planning acts as a critical accelerant for organizational cynicism. Systemic burnout requires structural workplace modifications. Resolving the syndrome necessitates a complete redesign of the underlying workflow architecture. The literature points to immediate mechanical fixes: targeted schedule modifications, adequate time planning, and absolute workload reactions. Modifying the workflow means overhauling teamwork protocols and smoothing out patient transitions. Rerouting the load prevents individual critical failure. Crucially, organizations must provide protected time for wellness activities during active work hours. Assigning self-care as unpaid homework adds to the clinical burden. Correcting mechanical workflow is necessary, but the structural repair remains incomplete with equally vital cultural modifications. Institutions must construct a blame-free environment. Providers need genuine psychological safety to openly share clinical experiences, discuss near misses, and process medical errors without fear. The system must deploy multidisciplinary psychosocial support teams, making them directly and immediately available to frontline staff during severe crises. There is also a physical requirement. Facilities need designated, safe areas where staff can temporarily withdraw and decompress from highly stressful clinical situations. Leadership has a mandate to actively dismantle the stigma associated with mental illness. Barriers to psychological support must be entirely removed. Finally, broad physician involvement in management decisions is the only proven method to reverse systemic inefficacy. Those executing the workflow must help design it. Sustainable risk mitigation in a hospital setting is impossible without active organizational engineering. Leadership must commit to correcting both toxic workflows and toxic culture. Relying exclusively on yoga or exclusively on schedule optimization will fail. The clinical literature unequivocally demands a multi-system integration of both individual and organizational interventions. Individual symptom management operates inside a repaired systemic structure. Both function together as interdependent components of a sustainable clinical environment. This integration is known as the bundled approach. It forms the foundation of the National Academy of Medicine's definitive clinical standard for burnout mitigation. The Academy's priorities require institutions to actively create positive work and learning environments, while simultaneously dismantling rigid regulatory and policy barriers. Healthcare systems must institutionalize clinician well-being as a permanent organizational value, backed by continuous measurement, baseline assessments, and funded research. Organizations are instructed to continuously reduce mental health stigma, engage effective technology tools to minimize clerical friction, and recruit an inclusive workforce. Burnout is a shared professional responsibility. Clinicians must engage in evidence-based self-care, and healthcare systems must engineer operational safety. Adopting evidence-based individual tools ensures the clinician survives the shift, but actively advocating for non-negotiable structural reform ensures the profession survives the future. Delivering excellent, consistent patient care depends on both.